All right, let's talk about the renin angiotensin aldosterone or RAAS system. So the question is, they work, but they work slow. So if the body wants to have the effects that they're going to make, which is to, let's say, increase in blood pressure, preserve the GFR, okay, or any effect that they're trying to make, they will make that effect, but slowly. It's going to take some time for them to work. But if in the same time, if you want to increase the blood pressure, reflex blood pressure, or reflex and maintain the GFR, increase in GFR, or maintain GFR, basically, the body has another way, which is fast, and that is the baroreceptors. And you can read that in cardiology, or when we do cardiology, we can talk about that. But they're the fast, quick, right away works. This one is slow. So let's talk about RAAS now. What do we have for the RAAS? Well, the RAAS activators, when we have a low BP, renal baroreceptors is going to sense that and activates the RAAS. One thing. Low sodium chloride delivery to the macula densa cells, again, same thing, going to stimulate the RAAS. Increase in sympathetic tone when you have the beta 1 receptor stimulation, it activates the RAAS. Okay, so we have the macula densa right there, and we have the JG cells, juxtaglomerular cells, present in between the afferent arterioles and DCT. Okay, and these are specialized cells. Okay, so now let's read, what do we have? So we have the afferent arteriole, and that's the glomerulus, and we have the efferent arteriole, and we talked about the JG cells. When the JG cell, let's say this one right here, let's talk about this. Macula densa senses the sodium chloride delivery, and it says it's low. Let's activate the RAAS. JG cells secrete renin. Renin goes in the blood and activates and converts the angiotensinogen into angiotensin 1. Angiotensinogen came from liver, and that angiotensin 1 is now circulates in the plasma, and from the lungs and the kidneys itself, we have ACE, angiotensin converting enzyme. It converts the angiotensin 1 into angiotensin 2. Okay? Angiotensin. And where are we getting the ACE from? From the endothelium of the lung vessels. Okay? Endothelium of the lung vessels. And this ACE not only does this thing, it causes the breakdown of bradykinin. Where did we get the bradykinin from? From the kinogen that forms the bradykinin, and ACE works on it, and it degrades the bradykinin. Okay. So now we have formed, as I mentioned, angiotensin 2. Now all of it, just remember angiotensin 2 now here. Angiotensin 2 is gonna work on all of this. It's gonna work on the blood vessels, which has the receptor for angiotensin receptor type 1, causes vasoconstriction of these blood vessels, increases the blood pressure, increases BP. Second thing, constricts efferent arteriole. When you're constricting the, you look, they have a nice picture here. They have constricted the efferent arteriole, so you have increase in filtration fraction that would preserve the GFR when there is renal blood flow decrease. Okay. So when you constrict, the question is how all of this is happening. So when you constrict the efferent arterioles, you're constricting these here. So you're putting the pressure, increasing the hydrostatic pressure in the increases the intraglomerular hydrostatic pressure, because you're basically blocking it out or decreasing the flow outside, going out into the efferent. So you're putting the pressure backwards, which increases the hydrostatic pressure. When you increase the hydrostatic pressure, more and more fluid goes into the filtration fraction, goes into the tubules to get filtered, right? So what was if you remember from the last lecture we had for the filtration fraction, the filtration fraction is equals GFR divided by renal plasma flow, right? So as the filtration, so see directly proportional and indirectly proportional. So when the filtration fraction increases, GFR increases or also is preserved by either increase or it remains the same constant. It depends upon renal plasma flow, how much we have decrease of that. But filtration fraction preserving GFR when there's a decrease in renal blood flow. Okay, so that's the way for on the glomerulus. Then it goes on the kidney and increases sodium hydrogen activity, which leads to PCT, which is in the PCT cells. What's going to happen is sodium, bicarb, and water reabsorption occurs, and this permits the contraction alkalosis. Okay, it goes to adrenal cortex, stimulates aldosterone. Aldosterone, we already talked about it, that it works on the alpha chelator and the principal cells. In alpha chelator, it causes hydrogen secretion and increase in hydrogen ATPase activity. In the principal cells, it causes sodium reabsorption and potassium secretion and increase in potassium conductance, sodium, potassium ATPase, and ENaC activity. And lastly, that same angiotensin works on the hypothalamus and leads to increase in thirst, in which you would take water intake is going to happen. You will take the water, that's one thing. Second thing, it also acts on the posterior pituitary and releases the ADH. Again, that ADH is going to go to principal cells, causes sodium causes water reabsorption. So taking water in from outside, as well as you're reabsorbing the water from the body, so that you're not secreting the water out, or you're not excretion of water is very low. Reabsorbing and also intaking. One more thing that's going to happen is, they haven't mentioned here, but that's due to ADH, you will have also increase in urea reabsorption. This increases serum urea levels, and that's basically why are we doing that, for water retention, because it's a solute that wherever it is, it's going to draw the water towards it. Okay, it increases the osmolality of, if it is in the collecting tubule, it is in the tubules, or it is in the not in the tubules. Wherever it is present, the water will follow it, because it makes the osmolar gradient. So when it is reabsorbed, it causes water retention. If it didn't make sense, that's why we will still talk about this later. Okay, so now what are the effects now? We talked about all of this, but what are we really getting to? When you are increasing the hydrogen ATPase activity causing hydrogen secretion, you're basically causing secretion of hydrogen into the urine. So hydrogen excretion, which causes metabolic alkalosis, because the acid is going out, it's going to cause metabolic alkalosis. Okay, for here you are just because you're causing the potassium to be secreted, so that potassium excretion is going to happen. That will give you hypokalemia in the body, hypokalemia. And for the rest of it, is just that you're causing sodium chloride, water, urea. They are getting reabsorbed into the blood. So for how long is it going to work? This is working, stimulating all of these things. But the thing is, it also has to be canceled out for something, right? It has to be destroyed, because we want homeostasis for the body. So how are we going to destroy this angiotensin? Well, we have an enzyme. It's called angiotensinase. Angiotensinase. It's going to degrade angiotensin into fragments and small peptide fragments, which is now called angiotensin 3. It has some now. This guy, the angiotensin 3 now, has only some biological activity. Okay, so yes, that's pretty much what we have for the all RAAS. So let's read now. Let's read this. Renin, it is secreted by the JG cell in response to decreased renal perfusion pressure, detected in afferent arteriole, right? An increase in renal sympathetic discharge, beta 1. And this is all about the one we talked about, the RAAS activators up top in the table. Okay. ACE catalyzes the conversion of angiotensin 1 to angiotensin 2, located in many tissues, but conversion mostly occurs in the lungs, produce a vascular endothelial cell in the lungs. And that's good they have mentioned this. Angiotensin 2 helps maintain blood volume and blood pressure, affects baroreceptor function, limits reflex bradycardia, important, limits reflex tachycardia, which would normally accompany in Presser's effect. ANP, BNP levels, relief from the atria, ANP, ventricle, BNP in response to increase in volume inhibits. These guys, they're going to inhibit your RAAS, and which is renin, angiotensin, aldosterone system, relaxes vascular smooth muscle in via cyclic GMP, causes increase in GFR and decrease in renin. RAAS is maintaining GFR here, they're increasing GFR, okay, and dilate the afferent arteriole and promote natriuresis and pushing the sodium out. And what was RAAS doing? So this is important to know this. Here, ANP, BNP, they inhibit RAAS. So let me actually do it here. They inhibit RAAS, one thing. They increase GFR, decrease renin, and causes natriuresis, sodium excretion. While on the other hand, the RAAS itself, it was causing sodium reabsorption and increasing the blood volume and everything, wherever it can, increases the blood pressure. Here they are doing the opposite. They're like, okay, man, we got a lot. So where are they coming from? They're coming from whenever you have volume overload, let's say, it's not technically volume overload, but let's say you have a CHF, congestive heart failure, the heart cannot pump out whatever it has. So it feels like, oh wow, the body's in overload because the heart can't pump it out, and it has overloaded with the volume, because you can't pump, the heart cannot pump out that volume outside. So it increases from atria ANP, and from the ventricles the BNP. So what do? They're like, why are we keeping increase in blood pressure when we have so much volume? So they decrease that. Why do we have RAS activated when we have so much volume already? Why are we having to increase in sodium and water absorption and drinking more water? Why are we doing that? So inhibit RAS. All you need to do is increase in GFR. And when you inhibit RAS, you basically decrease the renin levels too. And they're like, why do we have so much sodium in there? Because we are already in volume overload here. So just take out all the sodium out so that water follows and say bye-bye to all that water. But little they know, I mean, it's good for time being because your heart is going in CHF. The heart can't pump. But after some time, the heart is going to fail. And this is, we will talk about that in cardiology. But, this is the inhibitor. So ANP, BNP inhibit RAS. Okay, moving on, we have the ADH vasopressin. Primarily regulates the serum osmolality, also responds to low blood volume states, stimulates the resorption of water in the collecting ducts, also stimulates resorption of the urea in the collecting ducts. And this is what we talked about, right? Urea. Right here, I talked about ADH, urea gets absorbed, okay, in the collecting duct to maximize this is where we're talking osmotic gradient, corticopapillary. So see, I mean, the new first aids keep adding UL things, okay? I mean, I don't know. It's really good that they're doing it, so that we don't have to write much. But okay. Anyways, but understanding wise, we still need to go back to UL and do the questions and try to figure out because this is just one point. You're not going to understand anything from the point unless we look at all the explanation and why things are happening this way, why urea is able to have an osmotic gradient, and why don't we lose urea. Eventually we don't even lose urea. Urea just stays. It stays within tubules, goes out and stays here, then the water draws here. If it stays here, the water draws back. It all depends upon the level of ADH. That we also talk about in the renal section later on. But aldosterone now. Aldosterone, it regulates the extracellular volume and sodium content. Okay, increases release in hypovolemic states, responds to hyperkalemia by increasing in excretion. So aldosterone responds to hyperkalemia, causes potassium excretion. Okay, that's the aldosterone, but also primarily you have to regulate the extracellular fluid volume and sodium content. So I guess I'm pretty clear on this one. So let's talk about now the JG apparatus. Well, the JG Juxtaglomerular apparatus consists of mesangial cells, JG cells, modified smooth. These mesangial JG cells are modified smooth muscles of the afferent arterioles, and the macula densa, or the sodium chloride sensor located in the DCT. JG cells secrete renin. Who secretes renin? JG cells, in response to decrease in blood pressure, increase in sympathetic tone, beta 1, macula densa senses low sodium chloride delivery to DCT, and increase in renin release. So when the renin releases, it causes efferent arteriolar vasoconstriction, increases GFR. JGA. Now they're talking about the apparatus. Now let's look. I mean, look at this thing. We're talking about JG cells, meaning they are the specialized cells, right? And we then talk about macula densa. Now the question is, what is JG apparatus as a whole? Because now they're talking about not JG cells, they're saying JG apparatus. So apparatus means that when you combine these two together, when you want to talk about JG cells and the macula densa, Now you call that a JG apparatus. Okay, that's the JG apparatus. So JG apparatus, both of them, they maintain the GFR via RAAS. Beta blockers, if you were to block the beta blocker, beta 1, if you were to block it, you're causing low BP by decreasing cardiac output and inhibiting the beta 1 receptor of the JGA, decreases renin release. Okay, so that's pretty much all we have for the RAAS and JG cells.